Hello and welcome to WHO in today's press conference on global health issues. It's Monday, 17 March 2025, and we're here at WHQ in Geneva. Apologies for a very large start today, and I understand there are many other press conferences going on, at least here in Geneva, so thank you very much for joining us. My name is Christian Lindmer, and I will take you through today's press conference. Now, to save some time, I'll only introduce the people in the room here, and the other colleagues we come to later. Present in the room are Dr. Tedros Adhanom Ghebreyesus, WHO Director General. On his right side, Dr. Mike Ryan, Executive Director, Emergencies Program. Then we have Dr. Teresa Kazaeva, the Director for the Global TB and Lung Health Program. On the other side of Dr. Tedros, we have Dr. Kato Bryan. She's Director of the Department of Immunization, Vaccines and Biologicals. And last but not least, we have Dr. Abdi Rahman Mahmoud, Director ad interim for Alert and Response Coordination. And again, we have lots of other colleagues online, and we're happy to go to them when the occasion arises. With this, let me close already and hand over to the Director General for his opening remarks.
Thank you, Christian. Good morning, good afternoon, and good evening. First, some good news. Last Wednesday, Tanzania declared its outbreak of Marburg virus disease over. Although 10 people died in the outbreak, it could have been much worse. We congratulate the government, health workers, affected communities, and all partners who supported the response to the outbreak. WHO is proud to have played its part supporting the government with technical, operational, and financial support. And I would especially thank the President for her leadership. In Uganda, we're pleased that no new cases of Ebola have been reported since the 2nd of March, and there are no patients currently in care. Let's hope it stays that way. So far, 12 confirmed and 2 probable cases have been reported, with 4 deaths. WHO is supporting investigations to identify the source of the outbreak and any unknown transmission chains. And today, Burundi became the 18th country to roll out malaria vaccines in its childhood immunization program. The first phase includes 25 districts with the highest malaria burden. With support from WHO, Gavi, and UNICEF, the Ministry of Health aims to vaccinate more than 250,000 children this year. We expect that by the end of 2025, up to 25 countries will include malaria vaccines in their childhood immunization programs. These vaccines could save tens of thousands of young lives every year. However, many of the gains in malaria that have been made over the past 20 years are now at risk because of cuts to funding from the US for global health. To be clear, I'm not talking about the decision by the United States to withdraw from WHO. I will not comment on that today. I'm talking about cuts to direct US funding for countries through USAID, the US CDC, and other agencies. The impact of these cuts will be even greater, and we're already seeing them. There are now severe disruptions to the supply of malaria diagnostics, medicines, and insecticide-treated bed nets due to stock-outs, delayed delivery, or lack of funding. Over the last 2 decades, the US has been the largest bilateral donor to the fight against malaria, helping to prevent an estimated 2.2 billion cases and 12.7 million deaths. If disruptions continue, we could see an additional 15 million cases of malaria and 107,000 deaths this year alone, reversing 15 years of progress. It's a similar story with HIV. The suspension of most funding to PEPFAR, the President's emergency plan for AIDS relief, caused an immediate stop to services for HIV treatment, testing, and prevention in more than 50 countries. 8 countries now have substantial disruptions to antiretroviral therapy and will run out of medicines in the coming months. Disruptions to HIV programs could undo 20 years of progress, leading to more than 10 million additional cases of HIV and 3 million HIV-related deaths, more than triple the number of deaths last year. On tuberculosis, 27 countries in Africa and Asia are facing crippling breakdowns in their response, with shortages of human resources, disruptions to diagnosis and treatment, data and surveillance systems collapsing, and vital community engagement work deteriorating. 9 countries have reported failing procurement and supply chains for TB drugs, jeopardizing the lives of people with TB. Over the past 2 decades, US support for TB services has helped to save almost 80 million lives. Those gains, too, are at risk. On immunization, WHO's global measles and rubella network of more than 700 laboratories, which was funded solely by the US, faces imminent shutdown. This comes at the worst possible time when measles is making a comeback. Last year, there were 57 large or disruptive measles outbreaks, and that number has been increasing for the past 3 years. Since 1974, measles vaccines have saved nearly 94 million lives, but those gains are also at risk. The sudden cuts to US funding are also affecting efforts to eradicate polio, to monitor the emergence of diseases such as avian influenza, and to respond to disease outbreaks and humanitarian crises. Almost 24 million people living in such crises are at risk of not being able to access essential health services. More than 2,600 health facilities in 12 humanitarian crises have already suspended services, at least partially, or will do very soon. In many countries, the abrupt loss of US funding threatens to reverse progress in disease control, immunization rates, maternal and child health, and emergency preparedness. In Cox's Bazar in Bangladesh, the largest refugee camp in the world, diagnosis and treatment of hepatitis C has been disrupted, as well as disease surveillance, primary and secondary health care, laboratory services, procurement of supplies, and salaries of health workers. The US administration has been extremely generous over many years. And of course, it's within its rights to decide what it supports and to what extent. But the US also has a responsibility to ensure that if it withdraws direct funding for countries, it's done in an orderly and humane way that allows them to find alternative sources of funding. We ask the US to reconsider its support for global health, which not only saves lives around the world, it also makes the US safer by preventing outbreaks from spreading internationally. And because health is wealth, fighting disease around the world supports global economic growth and stability, which benefits the US. If the US decides not to restore direct funding to countries, we ask it to engage in dialogue with affected countries so plans can be made to transition from reliance on US funding to more sustainable solutions without disruptions that cost lives. Whether or not US funding returns, other donors will need to step up, but so too must countries that have relied on US financing to the extent they can. WHO has long called for all countries to progressively increase domestic health spending, and that's now more important than ever. Next week, WHO and the government of Colombia, together with other partners, will host the second global conference on air pollution and health in Cartagena. Every year, around 7 million people die from air pollution, mainly from respiratory and cardiovascular diseases. Many cities and countries are showing that change is possible, but progress is too slow. We call on all countries to make bold and achievable commitments at next week's conference to reduce air pollution and save lives. Finally, next Monday marks World TB Day. As I mentioned earlier, funding cuts to TB programs are having a severe impact in affected communities. In 2018, WHO established the Civil Society Task Force on TB to hear and amplify the voices of those communities so that we can reflect their needs in our work. To say more, I'm pleased to welcome Handa Eng Amgalan, a member of the Civil Society Task Force from Mongolia. Handa, welcome, and you have the floor.
Thank you, Dr. Tedros. Ladies and gentlemen, thank you for being here today. I want to begin by expressing my gratitude to the WHO team for inviting me to speak at this pivotal moment in the fight against tuberculosis and global health. Today, we stand at a critical juncture. 2 years ago, I joined Dr. Tedros at the UN high-level meeting where global leaders pledged to end the TB epidemic. Together, we set ambitious targets and committed to mobilizing at least $22 billion annually by 2027. Yet, as of 2024, 74% of this target remains unfunded, with similar shortfalls for TB research. The looming 2025 funding cuts further threaten this gap for global TB response, pushing it to the brink of collapse. To illustrate this impact, recent funding cuts have already hit more than 27 countries across 6 regions, leading to critical challenges, including staffing cuts among healthcare workers, resulting in interrupted service delivery, severe disruptions to diagnostics, delaying detection and treatment, impacted surveillance systems, preventing us from tracking and managing TB effectively. Community engagement is also impacted, including active case finding, screening, and contact tracing, which results in delayed diagnosis and increased TB transmission. Without urgent intervention, these systemic failures will only increase the spread of TB and worsen this global health crisis. As journalists, you know better than most the importance of facts and the urgency of a compelling story. Here is one for you. During the COVID-19 pandemic, disruptions in TB services caused 700,000 excess deaths. That is 700,000 lives lost to a disease that is both preventable and treatable. We cannot allow history to repeat itself. These numbers are not just statistics to me. These are personal. I'm a TB survivor. I have lived through the fear, the stigma, and the toll this disease takes, not just on the body, but on the spirit. I have also experienced the profound hope that comes from accessing timely care and the dedication of healthcare workers. But now, that care is at risk due to abrupt political decisions and funding challenges. The support of donor nations is critical to sustaining this fight. This is why the WHO Civil Society Task Force on TB, representing affected communities, and civil society from around the world has joined the Director General in issuing a statement ahead of World TB Day on March 24th. We are all calling for urgent actions from all stakeholders, governments, civil society, donors, and communities. We must prevent disruptions to TB services. Our response must match the scale of the challenge. We must prioritize domestic investment. Equitable and essential TB care needs to be protected within national budgets. We must safeguard critical resources, including essential drugs, diagnostics, and social protections for people with TB. We must strengthen partnerships, public and private sectors, NGOs, donors, and affected communities must unite to overcome operational and financial barriers. We must also enhance monitoring systems. Timely data and early warning systems are crucial to identifying and addressing disruptions before they escalate into crisis. Beyond these measures, we must also center the human stories behind these statistics. Every number you report represents a life: a mother, a father, a child, or a community affected by tuberculosis. Your work as media journalists is vital at this time to keeping this issue in the public eye. As a TB survivor from a country with one of the highest burdens of TB, and as someone working with refugees and migrants, I have seen firsthand the compounded challenges faced by vulnerable populations. Migrants, often excluded from essential health services, bear a disproportionate share of this burden. Tuberculosis does not exist in isolation. It thrives where people are displaced, stigmatized, and underserved. Ladies and gentlemen, we are on the brink of a crisis, one that could reverberate across borders and generations if we don't act decisively. 2 years ago, we declared on the UN stage, yes, we can end TB. Today, I must say to you, we must. Millions of lives depend on it, and the world is watching. Thank you very much, Dr. Tedros and the WHO team.
Thank you, Handi, for sharing your perspective, and thank you for the work that you and all civil society organizations do. WHO, I assure you, remains committed to working alongside you at this difficult time. And Christian, back to you.
Thank you, Dr. Tedros. With this, let me open the floor to questions now. Let me also remind everyone that you need to identify yourself properly in order to be put into the queue, and then raise your hand with the raise your hand icon. We'll start with Nina Larson from AFP. Nina, please go ahead and unmute yourself.
Yeah,
Nina?
can you hear me?
Now we got. Go ahead.
Okay, great. Thank you very much. For Dr. Tedros, you painted a fairly bleak picture of the impact of the U.S. Funding cuts. I was wondering if you've already been able to estimate if people have already died due to these cuts, if you know of cases where they have caused deaths, and if you have done a complete estimate of that. Thank you very much.
Let me see if we can talk to this, Dr. Tedros.
Teresa, do you want to
Or
speak
Teresa,
about
maybe.
the TB tour? Teresa can speak about TB tour.
Yes, I will try to respond to this important question from the perspective of tuberculosis. People with tuberculosis, in absence of the treatment based on the evidence, based on the science, have very high chances to die. And we've learned also from the COVID-related disruptions that led to the death, more than 700,000 excess deaths, and it's starting when disruptions last more than 3 months, and even 20% of drops in notification will lead to significant increase in TB deaths. And we will be following this situation closely.
Thank you very much, Dr. Kaseva, and we'll try also with Dr. McDougherty. She's Director HIV, Hepatitis and Sexually Transmitted Diseases, and then we have a colleague online here.
Thank you very much. The question is really important, and of course, the situation is fluid. And as we gather more information from countries and understand what is happening, we are seeing deaths. For example, we have anecdotal information coming forward, but as soon as opiate substitution therapy is stopped, there have been several cases of immediate, within the same week or so, of overdose deaths. If you are reading some of the literature in the media, there are some excellent examples over the weekend coming out from South Sudan of deaths from mothers and children not being able to access their antiretroviral therapy for HIV. And we have been working with modelers around the world. And clearly, if this goes on for a very long time, we could see up to 10,000 new infections and 10 million new infections and 3 million deaths. So yes, the reality is that we are just going to need time to be able to get the data in, but we are seeing effects on the ground right now. Thank you.
Thank you very much, Dr. Doherty. And in the room here, we have Dr. Kate O'Brien. She's director of the Department of Immunization, Vaccines and Biologicals. Kate.
Yeah, let me address this from the vaccine perspective. Vaccines obviously are preventive interventions. And so the actions that are taking place right now, which are compromising the ability to get vaccines to protect children, adolescents, and adults for the future, are going to result in deaths in the future. So the quantification of deaths right now is not the matter. It's that the actions right now are life-threatening. We estimate that there will be hundreds of thousands of additional deaths that will take place as a result of the actions to compromise the vaccine programs that are in place now, and many hundreds of thousands more as a result of the failure to actually deploy and introduce vaccines that are ready to go and to protect communities around the world. And that includes the continuation of the rollout of malaria vaccine and also the measles vaccine campaigns. One of the ways in which measles vaccine is deployed is through large-scale campaigns because it is probably one of the most infectious viruses we have anywhere in the world. And so those campaigns to assure that communities have at least 95% protection from the vaccines are really critical. And those campaigns are under deep compromise right now because of the loss of the people who actually carry out those campaigns and support governments to carry out those campaigns. So what we're seeing now is just laying the groundwork for hundreds of thousands of deaths that will happen on an annual basis in excess because of the withdrawal right now. Thank you.
Thank you very much, Dr. O'Brien. And we also have Dr. Teresa Zakaria. She's unit head for humanitarian and disaster action. Teresa, please.
Thank you very much. Indeed, a very important question from the humanitarian emergency side. So, as we know, this year there are over 300 million people who require urgent humanitarian assistance in order to remain alive and to be protected. Preliminary analysis of the impact of multiple funding cuts, but notably US funding cuts, can already be seen. We have quantified from the 12 countries for which we currently have data that over 23 million people are directly affected by reduced health services. Of course, the level of vulnerability will be quite different among the different groups of the 23.8 million people, but without urgent life-saving health services, all of these individuals will be at risk of dying. We also know that in these 12 countries, over 2,600 health facilities have been impacted. So the services have been reduced. Healthcare workers can no longer work, can no longer be paid. Many of them also directly impacted by humanitarian emergencies. We're looking at potentially a closure of over 900 hospitals in just these 12 countries and over 1,200 primary healthcare facilities. So it's compared to the population with humanitarian needs in these countries, we're already looking at over a quarter of them at imminent risk of deteriorating living conditions and eventually dying. What is also very important is that specialized services of those suffering from chronic diseases is particularly at risk, and specialized services such as gender-based violence response, sexual reproductive health services, rehabilitation services are even more impacted than overall. This is, again, it's very early in our determination and quantification of the entire impact, but already we're seeing how bad the situation is. And the more we will be hearing from these countries, there are 72 countries where there are people in need of urgent humanitarian assistance. And again, this data only comes from 12 of them. And so the more we will be hearing from the others, we will also see just how big the impact is. And we will be happy to also provide updates as they become available. Thank you very much. And back to you, Chair.
Thank you, Teresa. And over to Dr. Mike Ryan.
Just one very short word. Our efforts are fundamentally focused on keeping people alive, not counting the dead. And all of our teams around the world are focused on filling the gaps with our partners. We will continue to do our work. Our partners in the health cluster, our partners in the TB world, our partners in HIV, we are all trying desperately to fill those gaps. The gaps are vast, they are huge, but we are trying to do that. And we will focus less on counting the dead and more on saving those who are still alive.
Thank you all very much for painting this really somber but also encouraging picture. Next question goes to Helen Branswell from STAT. Helen, please go ahead and unmute.
Thank you very much, Christian. This is a question for Dr. Tedros. Dr. Tedros, you were in Washington recently. While there, did you meet with President Trump or with Marco Rubio, the Secretary of State, or anyone else in the administration? And if you did not, did you ask for meetings and were refused access to those individuals? Thank you.
Thank you very much, Helen, and over to Dr. Tedros.
Yeah, thank you. The purpose of my trip was for other commitments I had from some months ago in New York. And I was also in DC to meet some people, but I didn't ask to meet President Trump or Secretary Rubio because my trip was overly on some other issues. Thank you.
Thank you very much. Next question goes to Thomas Magna from Euractiv. Thomas, please go ahead and unmute.
Yeah, do you hear me?
Yep.
Okay, fine. Sorry. So my name is Thomas Magna. I'm journalist for Euractiv. I'm sorry, that's my first WHO press conference. I hope you don't mind me asking a slightly off-topic question, but the European Commission does not seem very active on the tobacco-related issues, which is a very, very huge issue. So what is the position of the WHO on this matter and on the fact that the EU is not making significant progress on the two of its key texts, like Tobacco Product Directive and the Tobacco Taxation Directive? Thank you so much.
Yeah, thank you very much. Thomas, I don't think we have anybody here today to address that issue, so we'll get back to you by email. Please write to mediainquiries@who.int. Thank you. Next question goes to Kerry Cullinan from HPW. Kerry, please go ahead.
Thank you, Christian. I would like to know from the DG, please, what is the WHO doing in terms of restructuring to address the loss of the US funds? And also, he mentioned that 8 countries were at risk of running out of ARVs. Would you be able to tell us which 8 countries those are? Thank you.
Thank you very much, Kerry. So I think we have Daniel Thornton online. Daniel, if you could start with this one.
Thank you very much. And I'll be happy to hand over to Mike Ryan, who's the chair of the prioritization group. But just to say that we are introducing immediate efficiencies and also going through a prioritization exercise to make sure we're focusing on the highest value added activities across WHO at all levels of the organization. We're also stepping up our outreach to donors to try and make up for US funding, both in terms of flexible funding and in terms of where the US government provided earmarked funds to polio, to emergencies, to infectious diseases, like in, as you've heard earlier, on TB and HIV. So a three-pronged approach from WHO. Perhaps Mike would like to add on the prioritization question.
Yeah, thanks, Daniel. And I think the first thing that's worth saying is that this is not this is a process in WHO. This has been going on for a number of years under the leadership of Dr. Tedros. We've gone through a large transformation over the last number of years, and therefore the organization is actually much more, I can say it as someone who's served for a very long time, much more agile than it used to be. So the idea that this is some terribly rigid bureaucracy that can't adapt is simply not true. This organization is adapting to the current realities. And the first thing any of you do at home when you're dealing with the reality of not having money, first thing you'll do is contain the costs. You'll stop spending on things that you might have spent on last week that aren't essential. Second thing you'll do is you'll try and raise more money. You work some more hours, you get some more salary, and then if this is going to be a long-term situation, third thing you'll do is you'll completely restructure the financing and your commitments in life. That doesn't mean selling the house. What it means is being able to look at longer-term structural changes to your life that allow you to survive. We're doing all three of those things, as Daniel outlined. We're severely containing our costs, and that they have been a lot of public discussion of what that is, from travel to meetings to all kinds of other things, trying to bring in our costs. The work on raising funds has been going on for a very long time. Dr. Tedros has led a process over the last number of years in increasing the assessed contributions that member states pay to this organization. Because in the end, the organization is over-dependent on extra budgetary resources, voluntary resources to WHO. Tedros has said many times publicly, long before this crisis, that we needed to shift to a financial base that was more based on having more contributions from our member states, which would allow our priorities to be set by our member states, not having our priorities set by those who give the most money. And that, to an extent, has been the problem that WHO has had for a very long time. In addition, Tedros has led a process with us all in senior management looking at building a better investment case for WHO. And there's been a very successful investment round for WHO over the last number of months in the last part of last year. However, having said that, the recent drops in extra budgetary funding from the United States, or the withdrawal of all those resources, plus reductions from other donors, have meant we've had to look seriously, not just at cost cutting, not just at fundraising, but at really looking to the future, looking to next year, and looking to the next 5 years. And we've already received instructions from Tedros to reduce our budget ambitions for the next foreseeable future. Our member states have looked very much at curtailing those budgets around 4.9 billion for a biennium. Dr. Tedros has instructed us to look at an even lower scenario so that we can be ready to deal with whatever comes over the coming months. I'm working very hard with our chief scientist, Jeremy Farrar, 2 regional directors, our head of business operations, and others, looking at how we can reprioritize our activities. The realities are that if the organization has less money, we can deliver on less things. We will try to be as efficient as possible, but the time has come for us to prioritize our activities. Our member states have asked us for a reprioritized, reworked program budget for the World Health Assembly in May. We will be ready to deliver that to the Assembly with the appropriate range of cost containment and the appropriate prioritization to move into the future. And if I give you just maybe one example in my own program, in the emergencies program, and we are a 3-level program. We operate at 3 levels of the organization. We have 400 people here in Geneva, but over 2,000 people in the regions and countries serving day to day. Our budget started out for the biennium, and for those of you who struggle with the word biennium, as I did for many years, it's a 2-year budget, so it's about 600 million a year. But if I take the budget of 1.2 billion for 2 years, we already have reduced our ambition for that budget down to 872 million. We know that we're not going to go. So we've reduced our budget targets, and within that, we've done 60 million of cost containment measures, and now we're looking at bridging financing to get us to next year. By the time we get there, our program, based on going from a budget of 1.2 billion down to a budget of around 872, that will result in a 25% contraction of the emergencies program. Now, contracting by 25 to 28% sounds easy on paper. But the question is, what do you want to stop doing? Do you want to stop doing Ebola? Do you want to stop doing emergency medical teams responding to major disasters in the world? Would you like to stop intelligence gathering so that we know what the next epidemic or pandemic will be? There are some terrible choices to be made, and I look to Kate and others and Meg and Teresa, who are making similar terrible choices, choices we would never have wanted to make. But we will ensure that this organisation moves into the future. We will be smaller, but we will be efficient as ever, and we will be stronger, and we will be ready to grow again when the time is right. But the idea that this kind of funding cut to WHO will in some way end WHO is not true. We have 194 member states still. We may have 193 next year. That will be a tragedy. I mourn for the loss of my US colleagues, not for the dollars, but for the loss of contact. I've worked in this space for 30 years, as colleagues beside me have as well. We speak every day with colleagues in the United States, with institutions around the United States. They are the core of global public health. They are the heroes of disease control. We want them still involved in global response and global prevention. We need them to be still involved. But we may have to move on without them and without those resources. If we have to, we will be strong. We will survive. If the US reconsiders joining WHO, we'll be even stronger. And as Dr. Tedros said, all organizations are in a constant form of evolution. We evolve. Having the US side by side, working with us to see how we can grow, how we can improve our performance, that's the best way forward. The best way forward is not to go to the sidelines and get out of the game. You need to stay in the game if you want to win. And I think the US has choices to make. They're a sovereign country, and they have the right to make any choice that they see fit to make. We just hope that they see fit to make a choice that's in support of the American people and in support of the people of the world.
Thank you so much. And we also have Dr. McDougherty, Director of HIV, Hepatitis, Sexually Transmitted Diseases on this one.
Yes, thank you. Back to the question about countries that were mentioned in the DG's remarks regarding those that are at risk of ARV or antiretroviral HIV treatment disruptions. Of course, this is a moving target. Every time we try to get more information, there may be more countries that come on and others that come off based upon how the waivers are being implemented and how countries are responding to freeze in funding. But currently, the countries that we're most worried about, those 8, are countries that you would know as well as being very, they're also very at risk for other outbreaks, infections, and emergencies, including Haiti, Kenya, Lesotho, South Sudan, Burkina Faso, Mali, Nigeria, and Ukraine. All of them, we're working with teams to see how we can avert challenges in the future. But next week, the list may be different. So please take the list as an indicative list, but it's not the final. Thank you.
Thank you, Meg. And now we have a group of journalists online who seem to be the first time with us. It's Tiffin Times. And thank you all there. But you asked many, many detailed questions. We'll have time for taking one now, which I'm going to read out. And then I think we're already at time anyway. Let me briefly read this out, and thank you again for being so active today with us, and welcome to WHO press conference. Carlos Antonio Montero for Tiffin Times asks, what WHO mechanisms are currently available for rapid scaling of clinical care capacities, e.g. ICU beds, oxygen supply, etc., in humanitarian settings facing concurrent outbreaks and conflicts like Sudan, Gaza, Ukraine, etc.? We thought maybe Dr. Teresa Zakaria first start, and then maybe Dr. Abdi Mahamoud. Teresa.
Thank you for this question. So in humanitarian emergencies, WHO has this institutional mandate, which is as the health cluster lead agency. This means that WHO is responsible for the coordination of many humanitarian health partners who are delivering health services to people affected by humanitarian emergencies. So we work hand in hand with our partners. Currently, WHO coordinates over 900 humanitarian health partners in some 30 countries. And the vast majority of these partners are national actors. And so this is basically our network and our capacity to mobilize resources to make sure that health services can continue to be provided to people affected by humanitarian emergencies. It can be for disease outbreak response. It can be for continuity of essential health services so that mothers and children can continue to receive the care that they need. And this is also how we scale up, invest more in trainings in order to make sure that the capacities, the technical competencies, but also just how people can expand the range of diseases that partners can care for is also optimum. I perhaps may also speak a little bit on the situation in Gaza, where a lot of our emergency medical teams, yet another mechanism for us to mobilize partners to deliver health services on the ground, is also very much central to how service delivery is maintained in Gaza since the start of the escalation in October of 2023. What has happened in Gaza is also the expansion of the national emergency medical teams. I think it's very important to remember as well that there are a lot of healthcare providers who are part of the communities affected by humanitarian emergencies. They have capacities, they have the knowledge of the population, they have the trust of the population. And so it's in these national partners that we are relying more and more as well to make sure that they are able to deliver the services as they had done prior to the crisis and will continue to do so even after the crisis. Over.
Thank you, Teresa, and Dr. Abdi Rahman Mahamoud, Director at Interim for Alert Response and Coordination, please.
Thanks. That's an excellent question. I think Teresa already covered. In terms of the mechanism we have, WHO, we have two mechanisms. One is our Global Health Emergency Corps, where we bring our 900 clusters within the Global Health Cluster, the 327 members of our Guam Outbreak Alert and Response, and over the 30,000 members of our national EMT, the Global International EMT. So these are workforce that's ready to support WHO anytime we need them. As Teresa mentioned in Gaza today, a lot of the health service provided by our AMT. When the outbreak happened in Rwanda, we relied heavily on all the surge we required from AMT, from our Guam and Global Health Cluster. So that's one side of what we're able to rely in terms of surge. On the other aspects within our health emergency preparedness and response, we knew from the lessons we learned from COVID, safe and scalable care is key pillar of our response. Within that, we have the infection prevention pillar, ICU, oxygen. So we have done, as you may have known, we don't want to go into the details, we were able to successfully build ICU capacities across a lot of low middle income countries because they never had that ability. We were established hundreds of oxygen processing plants, PSC, in Somalia, in Sudan, in a lot of Sahel countries with the support of our partners. So WHO is there, we have the guidance, we have the framework, and we have the partners. Right now what we need is the support to deliver that in the most critical aspect of the world.
Thank you both very much, and we have Dr. McRyan.
No, just very briefly, because we don't do this alone. and we've worked with a lot of bioengineering companies on, for example, on oxygen, worked with the producers of medical oxygen around the world, but importantly worked with our colleagues at UNITAID, and this has been a very strong partnership between WHO and UNITAID, and again shows the real power of multilateral partnerships. When international organizations work together to our strengths, we make progress. So we're really making progress on medical oxygen. Oxygen saves lives. Oxygen doesn't just save lives in epidemics. It saves lives in women giving birth with preeclampsia. It saves lives in TB. It saves lives in respiratory disease. It saves lives in intensive care units. It saves lives post-operatively. So oxygen is something we should focus on as one of the core deliverables within the health service, and the ability to scale is very important. And I think in that, when we talk about scalable clinical services, scaling something means starting from somewhere and scaling to somewhere else. Our problem in the world is we have so many very weak health systems that they're very hard to scale because we don't have the core basic health system in place. So we really have to work on building strong primary healthcare systems, strong basic healthcare systems that can then be scaled in a crisis. It's remarkable how resilient those systems can be, but there's a certain minimum capability that a system needs before you can really bring it to a higher level of demand or scale. So we should focus on building basic strong health systems, strong primary healthcare systems, as Tedros has outlined. And actually, I do recall, Tedros, in your manifesto, I think, or whatever, your first statements at WHO in 2017, you spoke about a scalable workforce. You spoke in your words about a global emergency corps capable of responding to these threats globally. And it's really good for us now to have what is a very strong global health emergency corps with the institutions in the Global Outbreak Alert and Response Network, the institutions in the emergency medical teams out with the emergency medical teams network, and the public health emergency operations centres all around the world. Almost every country in Africa has an emergency operations centre for public health now. Almost none had an emergency operations centre before COVID. Sustaining the gains, whatever we've paid a huge price in COVID, a huge price in human lives, a huge cost, but there were gains. And our gains in our ability to do things like oxygen at scale, to scale clinical services, to build better lab infrastructure, and to deliver better emergency operations coordination, they have all improved. So I do think that the question is well asked. So maybe a group of journalists, Christian, but they're asking smart questions.
Nothing against that. Now, with this, we've come to the end of our briefing today. Thank you very much all for joining, and to our new group here. We'll be sending the audio file and Dr. Tedros' remarks right after this press conference. And for any follow-ups, please write to mediainquiries@who.int. And with this, over to Director General for closing.
Thank you, Christian, and thank you to all members of the press for joining us today. And happy St. Patrick's Day to Ireland and all those who celebrate St. Patrick's Day. Thank you.